we'll go ahead and get started. Thank you guys for joining so much for our first session of the Behavioral Health Learning event. My name is China Locklear. I'm a project coordinator with the National Indian Health Board, and I'll be moderating today's session. We're really excited to have Dr. Taylor and Mary from the VA presenting on mental health and PTSD. So thank you guys so much. I'll give them a moment to introduce themselves whenever they start their presentation. But this session will last from 12 p.m. to 1 p.m. Eastern Standard Time. Please be aware that this session is being recorded, and please do keep yourselves muted throughout the session. If you have any questions for the presenters, please put them in the chat box, and we will have a quick Q&A session towards the end. And then if you want to, you can unmute yourself and ask your question as well, but I do ask that you just hold those until the end and keep yourselves on mute so we don't interrupt our presenters. And just as a reminder, please do make sure you sign out if you're wanting to receive the continuing education credits. That is the requirement. You have to sign in and sign out of every session. So just keep that in the back of mind whenever you're ending the session. So I'll go ahead and turn it over to our presenters. I want to give them as much time as possible.
Well, good afternoon or good morning, wherever you are, and thank you for inviting me. My name is Mary Cully. I work for VA's Office of Tribal Government Relations. I am Seminole and Creek. I'm also retired Air Force, spent 20 years in the military. I've been with VA since about 2005. And in my role as a tribal relations specialist, I have the pleasure of mediating relationships between tribal nations on behalf of the Secretary's office. So if you want to go ahead and put up my slides, I'll go ahead and start, and then I'll turn it over to Dr. Taylor.
Are you able to see the slides, Mary?
Yes, ma'am. You can go ahead and go to the next slide. I'm just going to give you a really quick brief on who OTGR is, Office of Tribal Government Relations. Our office has been in existence since 2011. It was under General Shinseki, our then secretary, who established our office. We're a small office of 6, and I'm one of 4 regional specialists. You can go and go to the next slide. And then this is just kind of gives you an idea of where the 6 of us are located throughout the US. Next slide. This is our chain of command. I use this because this is important, especially for tribal leaders who really want to understand what our hierarchy is in terms of our relationship to the secretary. So this helps with that. Okay, next slide. So Office of Tribal Government Relations has 3 main goals. Our first one is to implement the Secretary's Tribal Consultation Policy, which again, was established the year after, which would have been 2012 with VA. You can go to the next slide. Our second goal is to facilitate and increase access to healthcare and benefits for our American Indian Alaska Native veterans. As of January of this year, we had $162.1 million reimbursed back to IHS tribal healthcare systems in 2 urban Indian clinics for the direct care service that they provide to veterans. We have 115 actual tribal health programs and 74 IHS agreements at 108 different sites that get reimbursed from VA. And we still do outreach in trying to connect with other facilities also interested in reimbursement. Our third goal is to promote economic sustainability for our Indian veteran and Alaska Native populations. You can go to the next slide. As part of that economic sustainability, there's a specific type of outreach that we do within Indian country in which we actually bring VA out to those Indian communities with us at the request of tribal leadership. And we've been very effective in the way we do these claims, and I'll talk a little bit about that later on, but I just kind of wanted to give you a quick idea of some of the outreach we do. And next slide. So this is some of the outreach that our office does. Some of it is like leadership and tribal engagements. Part of also what we do as Office of Tribal Relations is whenever the secretary or the DepSec goes out to Indian country, our chief of staff, our team, depending on which of our locations he travels to, We provide him a brief on the tribe he's getting ready to meet, kind of the do's and don'ts, the cultural do's and don'ts for meeting with this particular tribal leadership. And then there's the national reimbursement information. We also have the National Cemetery Tribal Veteran Cemetery Grant Program, in which 6 tribal veteran cemeteries exist. They do have a list, and there's probably, I want to say they said about 5 more tribes that are in the holding queue in terms of getting the grant to build their own tribal veteran cemeteries. And then the presumptive conditions outreach events that we do as part of Goal 3, that just gives you an idea that in 2018, when we did it, we had about 1,100 veterans and widows that we serviced, and we held about 33 claims events in different locations. Next slide. Other parts of outreach that we do, VA Tribal HUD-VASH, which is a VA supportive housing program, that actually came about in 2017. And as a member of the intergovernmental agencies group on Native American homelessness, we were able to convince Congress and get Congress to include the term at risk of homelessness as part of the Tribal HUD-VASH supportive housing program, because of the cultural components that we brought to the table in terms of why typical or regular HUD-VASH does not work in Indian country. We also established the VA Tribal Advisory Committee Act of 2019. We had our first meeting January of this year. We just had a second meeting last week in Albuquerque. And then we also recently, the Vet Center has a federal advisory committee board, and we now have 2 tribal representatives on that board as well. One of the things that we're doing right now is reaching out to our urban Indian health programs to also get them started with reimbursement from VA. Right now, we only have 1 that is pending approval. And then once we get that approved, then we'll start reimbursing them for care as well for the veterans that they service. And we've also been trying to do outreach to our elders and our senior programs to understand more what we can do to service that population that we haven't been doing in the past. Next slide. So this is new legislation that was recently passed. It's very specific to tribal veterans. House Resolution 7105, which is Johnny Isakson, David P. Rowe Act. VA calls it the Mega Bus Act. There's about 7 pieces of legislation within that act alone that pertains to tribal veterans and things that we can do to positively affect how VA services our American Indian, Alaska Native veteran populations. One of those parts of the act is actually House Resolution 6235, which is we will start reimbursing for purchase referred care for those veterans to our IHS Tribal Health and our urban Indian clinics. And then 7105, which is the Parity and Access to Care Act. Basically, within VA, there's like 8 different priority groups in terms of VHA eligibility. And depending on which priority group you're in, you either, if it's service connected, there's no copay. If it's not service connected, you have a copay. Well, legislation that was passed basically took away the copay act for all Native American Alaska Indian veterans. So right now, our general counsel and the VHA leadership is working on getting that in place so we can no longer charge copays to our American Indian Alaska Native vets, and they're all excited about that. And then House Resolution 7105 is the State Veteran Home Grant Program, and that was amended and changed to include tribal nations to apply for these grants for anyone that's interested in establishing their own veteran home for their elderly veteran population. Right now, we only have 1 tribal veteran home, and that's with the Oneida Nation, and they've actually had theirs in place probably for about 3-4 years now. And then the VA Native American Direct Loan Program. And this is where any Native American, Alaska Native vet that has trust land or Indian land, VA is basically the bank in this, in that your tribal leadership signs an MOU with the Veterans Benefits Administration. And if a veteran wants to build a home on that Indian land, VA will loan them the money to build the home. whoever the natal representative is literally will hold this veteran's hand and walk through the entire process with them until the home is finished. What is unique about this program is we do not do foreclosure on the loan. Instead, we will sit there and work with your veteran to figure out why they're not making their payments, and if we have to change the way the loan is written so that they're making smaller payments and stretch the life of the loan out, VA will do that, because our ultimate goal is to keep the veteran in the home. And then just recently passed last week was the PACT Act regarding the millions of veterans who've been exposed to different toxic chemicals throughout their military career. And it covers a wide range, which I'm sure when we do our next presumptive event, we'll be seeing a lot of younger vets finally coming in and asking for assistance. Next slide, please. Okay, so I just kind of wanted to really briefly go over who OTGR is, kind of some of the things that we do, some of the things that we get involved in. But the biggest thing I really wanted to talk to you about is understanding the needs of veterans, which are often very silent from them. Their military trauma, the healthcare that the men and the women suffer from are so differently unique. And, you know, hopefully at the end of this session, you know, you'll be thinking about how VA and your facility can maybe better collaborate together for our veteran population. Next slide. So this is from Pamela Endeford. Many of you probably already know her. She did a presentation for VA early in the year, and she provided suicide data, which I want to share with you. And one of the things that she talks a lot about in her presentations are the stigmatized mental health related problems reported by our tribal communities. And when you look at suicide, mental illness, and sexual assault, especially for military personnel, it's pretty high up on there. You tie that into homelessness, depression. I mean, it just all kind of forms this vicious circle around our people. Next slide. This too is also from Ms. Endeford during one of her presentations, because what she wanted to share with VA was a lot of the risk factors and mitigation for suicide among our Native American veterans. I kind of want you to pay attention to community stigma, the perceived burdensomeness, community and cultural determination, participation in culture. Those are things that keep coming up a lot, especially among our women who serve in the military. Next slide. So in 2019, I did a first Tribal Women Veterans Summit. And I was surprised at the number of women that came out the first time we did it, because there's so much in the shadow, and it's really hard to convince them to come in and seek services for their health care. In 2020, we didn't do an event because of the pandemic. So in 2021, and during that time, I was getting a lot of phone calls and a lot of emails from a lot of our Indian women who served, and even some of our Hawaiian colleagues who were like, you know, had heard about me and said, I need some help. I don't know where to go. Can you help me? So, you know, I started making connections for them with local VA staff to get the needed services. So in 2021, we decided to do a Tribal Women's Virtual Summer Series. And I was really surprised at the number that attended the summer series in trying to understand what the need is for this particular population of women, only because they don't come in and seek services, they don't come in and apply for benefits. And one of the things that we learned with the first one, I wanted specifically to focus on their disability claims. I wanted them to hear what kinds of questions they should be asking, what kinds of assistance they should be getting from us as VA. And what we learned from that event was that a lot of our Indian women, Alaska women, our Hawaiian women, they will not speak to folks about their health issues. And if if they file a disability claim and they see it's a male service officer sitting there, they will turn around and leave. Because for some of them culturally, that's not something they do. That's not something they're permitted to do. They're not allowed to talk to, they don't talk to their own spouses sometimes about their internal health conditions, let alone speak to a strange man that they don't know who's not even native. So a lot of their needs go unserviced. A lot of them also do not consider themselves veterans either. So when I talk to people and I'm working with individuals in healthcare settings, I always tell them, don't ask them if they're a veteran when they check in. Ask them if they've ever served in the military. If they have a family member with them, ask them, have you or a family member served in the military? That's where you're going to get the answers that you need to know that, yes, this person served in the military. The other issue that came up a lot was how they feel invisible in both their native and their non-native communities. And from a mental standpoint, to be invisible in your own tribal community, it's extremely difficult from what a lot of these women are telling me that they're going through, especially from a cultural standpoint. And I'm going to talk about that here in a minute. But so, because this came out during the first summit, when we did the 2021 series, I went back to the women that attended the 2019 and I said, okay, I don't want to bring you the typical VA series. I want you to tell me what it is you want me to bring to the table. I want to know what you need VA to know in order for us to better service you. Next slide. These are a lot of the discussions that keep coming up from a lot of these women that served in the military. The marrying military to traditional culture is one that's very difficult, and it's still going on right now. In some areas, it's better than others. I think in the areas where the tribes are more matriarchal and patriarchal, they respect the women that have served, and they're not kind of pushing them in the shadows. In other areas, it's very difficult for them. I'll give you for instance, one female that approached me said that, at one event, her tribe asked her to march in with one of the flags to a powwow honoring veterans, and they wanted her to march in with her tribal veteran organization. Of course, she was the only female in that veteran organization. So as they were lining up, someone from another tribe walked up to her and asked her, what are you doing? She said, I'm marching in with my unit. He said, no, you're a woman. You don't belong here. Your place is in the back. So because it wasn't their ground, it wasn't their powwow, she didn't want to cause problems. So she quietly gave the flag to somebody else, and she stepped to the back off to the side, or her unit walked in. One of the elderly gentlemen from her organization later asked her, said, what were you doing? Why did you not walk in with us? And she said, that gentleman over there told me that it's not my place, that a woman's place is in the back. And because this gentleman was a cold talker, he made the point to get up and talk to the audience and tell them, don't ever disrespect their women that way, that these women serve just like they did. And in this particular instance, this woman worked explosive ordnance disposal. She was an EOD in combat. So these are a lot of when you think about mental health and how it affects our women, we're kind of doing it in our own tribal communities to our people. Intimate partner violence, domestic violence is a big one that they bring up. Missing and murdered women transitioning from the military to civilian status back into their communities, and moral injury are a big one also. A lot of the moral injury goes with the PTSD piece. And then the other thing they talk about is their tribal workforce, and how do I get my tribe to understand what PTSD is, and that just because I have it, it's not a reason for them to fire me. How do I get them to understand how to help me when I'm having a PTSD moment? Those are the kinds of things that keep coming up. And so these are the kinds of sessions and speakers I try to find to help not just the female vet or even the male vet, but to teach our staff, markers to look for, things to help in terms of how we service our own population. Mental health, females, inpatient units, basically non-existent. And when you try to add a cultural component to that for our American Indian women who are asking for mental health inpatient needs, there isn't one that exists out there. And that's when I talk about, you know, collaboration with your community, with your VA partners. You know, that's one that I'm really interested in hoping to start a discussion there for them. And again, it goes back to what we're learning, you know, about our women, that they're not speaking or applying for their own healthcare needs or their disability claims, don't consider themselves vets, and they feel invisible in their own communities. The other thing I want to put out there is that, you know, while I didn't do one in 2020, this year on November 3rd, Muskogee Nation is going to host me to do an in-person session this year. So I will get that to NIHB, the information to share. But I just kind of wanted to pass that on as well, because the more we do outreach to our female population, the more we find out how many there are out there. Next slide. And then this is just a real quick census of what's out there. According to the last American.
Hi, Mary.
Yes.
This is Carmen with NIHB. I'm sorry to interrupt. We are having some issues with your audio. It's really choppy. Is there, are you?
Set my camera down, maybe. Can you hear me? Can you hear me?
It's still pretty choppy, Mary.
Okay, this was my last slide. Just to show you what the female population and the male population looks like. So you can go ahead and go to the next slide. That's my contact. And then I'm going to go ahead and turn it over to Dr. Taylor so she can talk about the clinical component of kind of what I talked about for female vets.
Okay, can everybody hear me okay? Okay.
Yes, ma'am.
Yes. Great. I'm trying to watch chat also in case there are any problems. I'm going to ask your favor as I share my screen. So give me 1 second here. Okay, can you see my slides without notes?
We can see them, Dr. Taylor.
Okay, with or without notes?
Without your notes.
Okay, let me see if I can do a different option to hide the, there we go. Okay, so my name is Elise Berryhill Taylor, and I'm a Muskogee Creek citizen, just like Mary. I have not shared this with Mary, but my grandfather was also Seminole, so I carry some Seminole blood as well, and very proud of that. I'm a psychologist and a substance use disorder program manager and Veterans Court program manager for our Eastern Oklahoma VA Healthcare. I've been here for about 17 years. This October will be my anniversary. And before I came here, I was working as the behavioral health director for my tribe, for the Creek Nation, for about 8 years. And before that, I worked in the Pueblo community, in Navajo Reservation, Canyoncito in New Mexico. I worked before that, before coming back home to Oklahoma, I worked in Alaska with Alaska Native adolescents in treatment. So I'm really fortunate to have been able to experience a lot of different tribal cultures and ways. And I want to share a little bit of what I've learned with you all. And now as it pertains to tribal veterans. But first, before we get started, I want to dedicate this presentation to the memory of Joe Chamberlain. He was a friend to my father and a friend to many in the Native recovery community. And what Joe said was, we can say land back, we can fight forever, but we can't change much till we get our people sober. And I think that has a lot of relevance for what I want to talk to you about today. Also, I want to give you some background for this picture. On August 6th, we held the Broken Arrow Veterans Powwow in commemoration of the Mission 22 Memorial that recognizes those veterans who lost the war at home with PTSD. And I understand Mary also spoke during that same day. But here is a picture of Kiowa warrior, head lady dancer, and Kiowa Tribal Veterans Director, LaRue Goulattle, who was allowed to wear this war bonnet during the gourd dance. I have to say it was a really special day to witness. And as I shared this day with my council of women who are my tribal sisters and VA colleagues that work at different VA facilities, these were their responses. For the Ojibwe, the translation of the English word warrior is he or she who carries the people. What a true representation of that definition this is. Another sister said, as we decolonize and reclaim our authentic identities and social roles, I think we will see how much patriarchal concepts have masqueraded as tradition in our tribal ways. So exciting and heartwarming to be living today. Another comment was at a recent powwow held, one of the teachings given to all by the head veteran was to remember that in our way, women are indeed spiritually stronger and that this must be honored and respected. That's a very old teaching and I haven't heard it for years. It was very heartwarming to look around and see our young men listening intently and nodding. So I think this is a good way for us to begin our discussion on effective care for tribal warriors. I plan to present the rates of substance use disorders, PTSD, military sexual trauma, homelessness, depression, and suicide for tribal warriors so that you have a good understanding of their own personal wars. We're going to identify barriers to effective treatment for these conditions. And lastly, describe what the VA defines as evidence-based care and consider how to integrate traditional ways or tribal ways of knowing so that it is more culturally effective. First, let's spend a little time looking at the national demographics relevant to veterans so we can get a better idea of who and where they are. Most of the data that I'm going to be presenting to you are derived from the 2015 VA American Indian Alaska Native Report, the 2010 Census Report, and the Department of Defense and Oklahoma databases. So you can see here that over 50,000 veterans were estimated to reside in these states from greatest to least numbers. On this slide, we can see the numbers of service members and veterans that were in the OIF operations. And so you can see that 22,000 tribal active duty served across the armed forces in 2012. And then in 2010, there were approximately 156,000 tribal veterans and 10% of those were women. Here's another interesting finding that tribal veterans were younger and they were less likely to be married, with the median age being 59 compared with 64 for all other veterans. In the next few slides, we'll review the data specific to mental health and socioeconomic conditions that affect tribal veterans. We'll start here with the rates of PTSD among tribal Vietnam veterans, which is 45 to 57%. Compared with other groups, you can see that tribal veterans struggle with PTSD at a higher rate. As with adverse childhood experiences, we know that our tribal veterans endure intergenerational trauma that creates multi-layers of wounding, which goes untreated and is more severe than other veterans who may receive timely access to care. So we'll be examining those barriers to care in later slides. Furthermore, due to the historical and present day traumas of our people, in other words, forced removal, cultural genocide, discovery of mass graves of our children in boarding schools, and human rights violations like the missing and murdered Indigenous women epidemic, our communities continue to be in peril. It behooves us to take a closer look at the effectiveness of care that we provide to our tribal veterans. Now, in 1994, a study by Home revealed that up to 80% of Vietnam-era tribal veterans reported being depressed, 77% had sleep problems, 71% had fits of rage and anger, and 81% admitted to drinking too much. I'd like to bring your attention to this picture I took of the Mission 22 silhouettes in Broken Arrow, Oklahoma, commemorating veterans who died by suicide. To further highlight this issue, according to the National Violent Death Reporting System of Oklahoma, the tribal veteran suicide rate is 19% higher than whites, 3 times higher than Blacks, and 2 times higher than Hispanics. More data from this report indicated some other suicide risk factors for all Oklahoma veterans. So for those with a high school degree or less, they were twice as likely to commit suicide. For older veterans, health problems were ranked as the #1 risk factor. And for younger veterans, it was intimate partner problems. I think this slide illustrates the dire need to address the psychological wounds of war and historical trauma suffered by our tribal veterans. In addition to psychological wounds, socioeconomic disparities are significant obstacles to care and to quality of life for our veterans. As such, homelessness and suicide prevention are top priorities in VA. In 2009, 76,000 veterans were homeless on any given night. 70% of those also had a substance use disorder. Keep in mind, these numbers have probably increased since COVID. Furthermore, homelessness for our tribal veterans is unique because of the rural and reservation-based communities where they live. In the past, they did not meet criteria for housing through VA, although that has improved greatly with the implementation of tribal HUD-VASH. But in some cases, they didn't even meet criteria for tribal housing. Still yet, there is a crisis shortage of available housing in rural and urban communities, whereas prior to COVID and rising inflation, there were greater disparities between these areas. I want to spend just a minute here reviewing the top priorities for tribal veterans, considering the data that I just presented. And based on the VA's Office of Tribal Government Relations, or Mary's office, in their 2016 tribal consultation with all 567 tribes, these were the top 5 priorities. So I think it's representative of what we are seeing so far. If we do a deeper dive into quality of life indicators for tribal veterans, it's apparent that they are burdened with additional challenges. Tribal veterans are ranked poorly for education, income, home ownership, employment, lack of transportation, and distance to care. Both rural and urban tribal veterans had more medical and mental health diagnoses than other groups, had higher service-connected disability ratings, and were less likely to have any kind of healthcare coverage than other veterans. Furthermore, access barriers to care included lack of appropriate diagnostic services and specialty care such as mental health services. Also, they're more likely than non-tribal veterans to delay care due to inability to get timely appointments and to reach their providers. Help-seeking experience is another factor when examining the health disparities of our tribal veterans. More barriers to care include that they are 4 times as likely as non-tribal veterans to report unmet healthcare needs. They report impersonal care and lack of knowledge about VA services. And lastly, they experience significant access problems with VA, tribal, and IHS care because of their tribal veteran status. Most tribal veterans don't understand the VA system and avoid it altogether. However, I believe that they'd prefer to go to the VA for specialty care that may not be offered in tribal care, such as mental health treatment for PTSD and SUD, cardiologists, orthopedic specialists, and surgery, just to name a few. In a 2016 study by Kaufman, focus groups were held with 3 different tribes. One tribal veteran described a preference for VA care by saying, IHS doesn't understand combat vet mentality. Those of us working in VA recognize this sentiment because veterans feel stigmatized in seeking out treatment in their community, as Mary was pointing out earlier. They sometimes feel that while the community doesn't understand them, the VA provides a setting for camaraderie with other veterans and with providers who know military culture and are not squeamish about trauma. Another challenge for the tribal veteran is that they often feel caught between the 2 confusing systems of tribal and VA healthcare, so they don't receive care at either. They perceive too many hurdles associated with the bureaucracy of both, but even more so with VA because of its size and because they're more familiar with tribal care. The accumulation of negative experiences in help seeking is a profound barrier to getting timely and effective treatment. Now I want to highlight the 2 access to care issues related to cultural and racial barriers. They're more likely than their non-tribal counterparts to report access to care problems due to racial discrimination and cultural misunderstandings. So why examine culture in treatment for veterans? First, the acknowledgement that veterans experience cultural barriers to care should provoke the VA to placing a higher priority on developing culturally responsive services. Culturally responsive services utilizes the resilience and brilliance of traditional ways of knowing, healing, believing, and living that will enhance the effectiveness of treatment and improve the quality of life for veterans. In the next few slides, I will present the evidence-based treatment in VA and contrast those with traditional healing practices. Ways to decolonize and indigenize treatment, as well as training health professionals, will be suggested. The VA has been at the forefront of setting the standard of care for private, community, and public health sectors, especially for the delivery of mental health care to veterans. In fact, algorithms for treating veterans with PTSD and substance use disorders are provided in the VA and Department of Defense in these clinical practice guidelines. These are the guidebooks that we follow in determining evidence-based care. Evidence-based treatments are defined as those clinical practices that have been proven in research and in the health field to be the most effective treatment for physical and mental health conditions that affect veterans. But little is really known about how effective these evidence-based treatments are with our tribal veterans. Here you see the evidence-based treatments for substance use disorders. Group therapy is still the preferred mode of treatment for treating SUD. Intensive outpatient treatment programs are considered highly effective treatment for moderate to severe SUD. At VA, we offer most all of these EBTs. We treat co-occurring SUD with PTSD and other mental health conditions. We also offer detoxification and residential treatment. The primary medications that are used to treat addictions in the VA include buprenorphine, Suboxone, Sublocade, naltrexone, and methadone for opiate substitution. With the rise in opiate addiction and most recently increase in fentanyl deaths, the VA makes these medications and naloxone kits readily available. Regarding PTSD treatment, EBTs are individualized and manualized trauma-focused psychotherapies that have a primary component of exposure and/or cognitive restructuring that includes the list on this slide. Cognitive behavioral therapy treatments for insomnia, nightmares, and depression are also utilized to treat veterans who have co-occurring PTSD with these other conditions. Some of the EBTs for treating depression and suicidality are included in this list. Please note that the Veterans New Crisis Line is 988+1, but the old 1-800 number is still active and can also be used for now. I want to take a minute to discuss the increase in women warriors receiving care at the VA. A recent study by Brooks et al. Indicates that tribal veterans in both rural and urban areas were more likely to be female, report military sexual trauma, and receive care for diabetes, PTSD, TBI, addiction, mood disorders, anxiety, and hypertension. Furthermore, tribal female veterans reported more military sexual trauma than their non-tribal counterparts. Military sexual trauma has gained heightened urgency as we see veterans more willing to disclose this trauma. The EBTs mentioned before are available either in individual and/or in group formats to veterans of all genders who've experienced MST and other sexual trauma. About 1 in 4 women who use VA care experience MST, and almost half of all men who use VA care have experienced it. Sometimes it takes years before a veteran will be comfortable enough to share their experience in therapy. That's why it's so important to create a milieu of trust and acceptance so that they'll feel safe enough to talk about this issue. MST treatments are similar to the other PTSD treatments like cognitive processing therapy, prolonged exposure, and nightmare treatment, and have their own programs. And another subpopulation within our tribal veteran group is LGBTQ+ veterans. I want to take a minute to mention that most VA facilities have an LGBTQ+ program and coordinator that provides oversight to the primary care and mental health teams that treat LGBTQ+ veterans. We want them to be offered treatment in a setting that is culturally compassionate and inclusive of all veterans. Now that we've talked about the prevalence of mental health, addictions, socioeconomic disparities, barriers to care, and VA treatments, we must examine the effectiveness of evidence-based treatments in the context of culture. It'll be critical to decolonize treatment. When we think about decolonizing treatment, we can see how it benefits not just the veteran, but also the providers who are treating them. In fact, professionals in VA and in tribal communities are beginning to realize that what we're doing is not enough to make lasting change and heal wounds of war. Therefore, we will consider the impact of integrating traditional practices with VA evidence-based treatments. Let's start here with the definitions of traditional medicine and traditional Indian medicine based on the literature. Traditional Indian medicine is the expression of traditional spirituality and participation in ceremonies and Indian medicine, all being tribally specific in terms of the expression of spiritual and traditional beliefs. Tribal community treatment programs have been the forerunners in treating our own people, while VA has been recognized as setting the mental health standard of practice for veterans. When it comes to treating tribal veterans, there is much that both can learn and gain from each other. Since the beginning of time, our people have had the knowledge to heal ourselves. It's been within the past several decades that tribal communities have begun to decolonize and incorporate those ways into our healthcare systems. Many of you are aware of this. However, it's only been within the last decade that the VA has gained this situational awareness. I think we're currently riding a wave that will result in greater efforts to incorporate some of these traditional healing practices into VA healthcare, and it's long overdue. These may include some of the practices that are on this list, bearing in mind that it will vary depending on tribe and individual. Not every tribal member is as connected to their culture as others, so we must respect individual differences within our own people. Others choose to keep their practices more private, and that should also be respected. Some of these practices on the list are offered at a few VA facilities. Mary Coley may be able to tell you what is available. For example, sweat lodge ceremony, talking circles, Native American recovery, and other community healing may be integrated in some VA facilities where there is greater partnerships with tribes. That's what's needed if we're going to decolonize VA care with tribal veterans. In addition, we must focus on decolonizing training and indigenizing academia. First, we start by raising awareness of our people's issues, not being silent when we have opportunities to advocate for our communities. We've been silent too long. By raising awareness, we can increase the concern of others regarding the health disparities and historical trauma experienced by tribal veterans, which may lead to more professionals entering health careers in our communities. It'll be mission critical to indigenize their training by having tribal clinical supervisors and teachers who can show them how to provide culturally responsive treatment. In my own clinical training, some of the most powerful teachers were community members who shared cultural wisdom, knowledge, and healing at the grassroots level through talking circles, sweats, gathering of Native American healing groups, and leading by example. Finally, healing for the healer should not be overlooked. It takes tremendous energy to walk with others through their trauma. Therefore, good self-care is vital for healers to avoid burnout and compassion fatigue. A holistic approach to self-care is recommended. I referenced my Council of Women earlier. This small group of tribal colleagues didn't start with the intention of self-care, but it has evolved into just that. Find your council of men, women, or elders to help you stay committed to your own self-care and to receive wisdom. Finally, I want to make this last point about advocacy and speak to our need for social justice warriors. Notice the pictures that I've chosen for this last slide. Here, my cousin and my family joined the protest against DAPL in our own city. Every day, though, there are threats to our sovereignty and existence. We see this with McGirt versus Oklahoma, the MMIW epidemic, water rights, DAPL, as was mentioned, and so many more. There are threats to our culture and to the protection of our children with recent challenges to the Indian Child Welfare Act. Cultural identity theft is burgeoning with those who assert tribal identity with no blood and/or cultural ties to tribal communities. Language preservation programs, family stories, cultural legacies, and inheritances are being stolen by those who want to copyright and profit from what the Creator gave us. And lastly, they want to erase all evidence of our Holocaust and stop us from speaking about tribal history. We run the risk of repeating the past, lest we are silenced and our stories forgotten. This is being played out now in Oklahoma with House Bill 1775, which prohibits discussions in schools that would make students uncomfortable, like hearing about historical trauma and cultural genocide committed against our people. Jim Gray, former principal chief of the Osage Nation, expressed concern about the impact of this bill after a teacher withdrew their decision to teach from the Killers of the Flower Moon book for fear of repercussions. We have our work cut out for us. We are the ones living now who must speak for our ancestors and for our 7 generations to come. It should motivate us to improve the care that honors and promotes healing for our tribal veterans and our people. They've given everything for us. It's time for us to give our all. Mado, thank you for your time and attention.
Great. Thank you so much, Dr. Taylor and Mary, for that wonderful presentation. We will go ahead now and take questions. So if you have questions, you can put them in the chat box or feel free to unmute yourself. Okay, I'm seeing thank yous in the chat. If anyone has any questions, you can just throw those in there as well. The slides will be available if Dr. Taylor and Mary allow me to post them.
I'll send mine to you right after this.
You have mine, feel free.
All right, perfect. So give us a few days to get those posted on the website. And then I will put it in the chat where they will be located. Just give us a few business days to get the recording and the slides posted.
I think everybody's too hungry to ask questions.
I think so too. It's early, right? It's almost lunchtime. Don't be shy. We still have 15 minutes.
Well, if there's any interest in reaching out to me later, I'll be glad to share my email address here for the VA in the chat. And thank you for your attention and listening to our presentation. So really feel honored to be able to present to you all. And I want to thank Mary for asking me to co-present with her.
I can't get my video cleared, but I want to thank you too. My machine's acting up. There it goes. Thank you too, China, for inviting us to speak. I'll also send you the flyer for the Tribal Women Veterans Summit in case anybody's interested.
That'd be great. And we can post that at NIHB as well if you're okay with that.
That's fine. Thank you.
Perfect. We have a lot more thank yous in the chat box. Everyone's saying how much they learned and how much they greatly appreciate you sharing your knowledge. Does anyone have any questions?
If there's no other questions, then maybe we can give them a little extra time back just to get ready for the next thing.
Yeah, absolutely. So both of the presenters' information is in the chat, and I'll go ahead and post that link to where the recordings and the slides will be. Like I said, just give us a few business days to get that posted onto our website. Hopefully we should have that up by Monday of next week. But I really do want to thank our presenters today for giving us such a wonderful presentation, sharing your knowledge with us. It was just great to hear you guys speak and learn so much about what you guys are doing at the VA. I really appreciate it. So I will give you guys about 10 minutes back into your day. Our next session does start at 1:15 Eastern Standard Time. Whenever you log out of this session, don't forget to fill out the evaluation form. If you're trying to get continuing education credits, that will be the way that you receive those, is by signing out. So I will give you guys a few minutes back into your day. I'll stop the recording now.